Good afternoon. I'm Rachel Sachs, the Senior Director of Education at the Cancer Support Community. Welcome to our Facebook Live today. For those of you joining for the first time, let me just tell you a little bit about the Cancer Support Community. For more than 35 years, we at the Cancer Support Community have been a relentless ally for anyone impacted by cancer. We help individuals manage the realities of the disruptive disease and try to get them back to normal. Whether accessing our free services in person at one of our 175 locations, online, or over our toll-free helpline, you are getting a team of licensed professionals providing patient navigation, financial counseling, genetic counseling, pediatric support, and more. Today, we are going to focus on how multiple myeloma impacts the African American community. Some of you joining us today may already be familiar with multiple myeloma or another type of blood cancer, while others may be new to the topic. We are here today to better understand this type of cancer and the treatments available for it. I'm excited and very grateful to have with us today a leading expert who will help us understand the many challenges, considerations, as well as approaches that are being used to treat this disease, specifically in the African American community. We are joined today by Dr. Craig Cole of Michigan State University. Dr. Cole is the Director of Clinical Research in Hematology, Oncology, and Multiple Myeloma at the Michigan State University College of Human Medicine at the Breslin Cancer Center. Dr. Cole has been practicing hematology for over 20 years and has been the primary on-site investigator for over 30 clinical trials and participated in over 50 clinical trials in multiple myeloma and malignant hematology. He devotes his time in researching multiple myeloma, patient education, and empowerment in working with local and national patient advocacy associations. Welcome, Dr. Cole. And we are so grateful today for the support of our money fundraisers and funders, Amgen, Bluebird Bio, Bristol Myers Squibb, GlaxoSmithKline, Farm Therapeutics, Sanofi Genzyme, and Takeda, and bringing this Facebook Live about multiple myeloma. Thank you to our funders. Dr. Cole, let's get started. Can you tell us what multiple myeloma is and how common it is?
Well, yes, and I guess first thing, Rachel, is a huge thanks to the cancer support community for inviting me today and actually holding this Facebook Live to talk about a subject that's near and dear to my heart and has been really the core of the work that I've done through medicine. And so thank you for that. And I was just going to show you a slide to kind of help answer that question, that multiple myeloma is a cancer of the plasma cell. So inside the bone marrow, there are plasma cells that produce antibodies that help us fight infection. And just like any other cell in the body, those plasma cells can turn cancerous. When they turn cancerous, then they will grow out of control inside the bone marrow space. They'll actually leave the bone marrow to go to other bones and cause holes in those bones. And it will produce abnormal amounts of antibodies or proteins, which is a good way to detect if someone has myeloma, is to look for those abnormal proteins produced by those plasma cells. But also those plasma cells, those proteins can cause problems by getting stuck in the kidneys, causing kidney problems. That the protein and the plasma cells can cause anemia, causing low blood counts. And when they go to the bone, they can destroy part of the bone, not only causing holes in the bones, but also raising the blood calcium, which can make people, feel poorly. And so that's kind of multiple myeloma in a nutshell.
Okay, thank you. And how common would you say it is and prevalent in society?
So I can show you a slide about that too, actually.
Perfect.
The uh, Mr. So it's the second most common blood cancer behind a non-Hodgkin's lymphoma being the most common. There are about 32,000 new cases that were diagnosed last year. The incidence of myeloma has been slowly rising over the past several decades. The great thing is that there are 131,000 people living with myeloma right now. That number, if you look back in 2010, was more like 40,000. And so there's been a huge increase in the number of people living with myeloma because of all of the great technology and the new clinical trials that have brought really revolutionary and novel therapies to the forefront of myeloma, saving lives. It is a disease of adults. And as I get older, I'm pushing the term older person up into the 90s and hundreds. And so adults are usually diagnosed with myeloma. But it's three times more common in people of African descent than other races. And so really that is just not something about being in the United States and being African American, but across the planet. That if you look in South Africa, if you look in Europe, people of African descent have twice the incidence of Caucasians with this disease, and three times the incidence than Native Americans and people of Asian descent.
Dr. Cole, do you have any sense of why that is?
Yeah, that's a super good question, and really kind of the focus of a lot of the research that has been going on. We've looked at and we've seen that African Americans will present with myeloma about 4 years younger than Caucasians, and really kind of the bottom line of your answer is that we really don't know why the incidence is higher in African Americans. We know that the biology of myeloma is different in African Americans, that they'll have, and many times more aggressive disease, that they'll have more anemia and a protein that is a chemical that's released by the myeloma cells when they're dividing, the serum lactate dehydrogenase. When the cells are dividing, they release that. And that African Americans have higher LDHs, more anemia, more high calcium levels. We also know that African Americans are more likely to have specific mutations that cause myeloma, and specifically the 1114 translocation, which has really become an incredibly hot new area of research, with new drugs being developed specifically for that mutation, again, found more commonly in African Americans than in people of African descent than of European descent. Also, African Americans are less likely to have the highest risk mutations associated with myeloma. So deletion or mutations of P53 or the 17th chromosome are very high. We'll talk about that in a second, but very high risk for myeloma. And African American and people of African descent are less likely to have those high risk mutations. And there was a study that was done by the VA medical system with a question of, if all things being equal, how do the different ethnicities do with myeloma if treated equally and have equal access to care? And actually, in that study, African Americans have a better survival with myeloma than their Caucasian counterparts. And so there are biologic differences between the ethnicities with myeloma. There's some evidence that myeloma may be an inherited disease in some groups. In a recent study that was done, that African Americans and people of African descent are more likely to have a related risk of myeloma than Caucasians. But we can't explain that racial difference based on tobacco use, socioeconomic status. We do know that obesity increases the risk across the board, and that studies have shown that there's a higher risk of obesity in African Americans, which then relates to a higher risk of myeloma. The only significant environmental exposure is ionizing radiation. There are some suggestions that chemical exposures over long periods of time, pesticides, diesel exhaust, nickel exposure can also increase the risk. But specifically, why do African Americans have a higher risk is really a very, very, very high priority area of research to figure out why is that. Because we hope that if we can figure that out, why do African Americans have such a high incidence? Why do people of Asian descent and Native Americans have such a lower incidence? Will really give us important insights into the disease.
That was very comprehensive. Thank you. So it sounds like there's a lot of research out there. We're just continuing to try to find those answers.
Oh, yes.
Okay. So the American Cancer Society estimates that 34,920 new cases of multiple myeloma will be diagnosed in 2021 in the United States. But out of those, some of those patients have been asymptomatic, I'm sure, meaning they didn't show any symptoms at all. So can you explain to our viewers in basic terms how myeloma is diagnosed and what exactly they should be looking for?
Yes, and that's of course, they're all super good questions. I mean, I love answering these questions because they're really important. And instead of me saying I'm not quite sure why, I have the answers to that question. So
excellent.
We know that all myeloma begins with a condition called MGUS, or monoclonal gammopathy of uncertain significance. And that's very common. And it is, if you look, it's about 3% of all people over age 50, and about 6% of African Americans have the monoclonal gammopathy of uncertain significance. They have no symptoms. It is not myeloma. It's a precursor disease to myeloma. And that is detected usually incidentally when people have a blood test and they see a higher protein. We talked about that protein level that's produced by those abnormal plasma cells. If there's a small number of those abnormal plasma cells, they produce a small amount of protein. And sometimes those proteins can be detected on just routine blood tests. So a lot of times you see a lot of patients with MGUS, and it is usually because they've had some blood tests done. They see their doctor sees a slightly high protein, and then they do a test to investigate why the protein is high. The testing that is used to detect myeloma is the same tests that are used to detect smoldering and MGUS, which is the protein electrophoresis. So electrophoresis means it separates out the different proteins in the blood, and that protein electrophoresis can find that specific protein made by those plasma cells. So the protein electrophoresis can detect those proteins made by those abnormal plasma cells, and a companion to that is something called the free light chain analysis, or they're fragments of that protein, free light chain of proteins that can be picked up on another test. So the combination of the serum protein electrophoresis and the free light chain test will detect about 99% of MGUSs and most patients with the vast majority, I should say, of smoldering and multiple myeloma. So there are lots of people out there that have MGUS, but only a fraction of those will actually develop another disease called smoldering myeloma. Smoldering myeloma is when there's more plasma cells inside the bone marrow, they're producing more protein, and the lab tests become more abnormal. If you do a bone marrow biopsy, you'll see that they're about 10% instead of 1%, which is normal. You'll see about 10 to maybe 50% plasma cells inside the bone marrow, but those patients have absolutely no symptoms. And some of them, not all, but some of them will progress into true multiple myeloma, the cancer that's associated with the plasma cells. Then you have much more in the way of plasma cells inside the bone marrow, and they're causing problems. They're causing, and we name those problems the crab problems, or the crab criteria. With the C being calcium elevation, I mentioned earlier how those plasma cells will leave the bone marrow, go to the bone, and then dissolve some of the bone, releasing calcium that can make people feel very tired and fatigued. That protein that these plasma cells produce can get stuck in the kidney, causing low kidney function. It clogs up the filter of the kidney so that the urine sometimes will be really foamy, but mainly the kidneys can't clear out the abnormal proteins or the abnormal chemicals in the body. So people can feel tired with that. Because those plasma cells are in the bone marrow, the blood factory, they'll crowd out the normal function of the bone marrow, and then patients will have low red blood count, so they'll have anemia. And then I've mentioned earlier about how these plasma cells will leave the bone marrow and go to the bones, causing destruction of the bones or lytic lesions, which can be detected on x-rays or on CT scans or PET scans. And so if a patient has lots of protein in their blood, their bone marrow has lots of plasma cells in it, and they have the CRAB criteria, then we definitely want to treat those people. A new thing that's been about 5 years in the making is that the research has shown that if patients have lots and lots of plasma cells in their bone, more than 60%, with 1% being normal, or if they have a high number of those light chains, those fragments of protein checked on that free light chain assay, or if they have more than one lesion on a really sensitive scan, they have about a 90% chance of having one of those crab bad things happen to them to become symptomatic. So those folks we treat. So for MGUS, we just monitor them. Again, very, very common. Only a fraction of those people will turn into myeloma, about 1% per year. Smoldering myeloma, we also watch carefully and enroll those folks on clinical trials to see if early intervention before patients have symptomatic myeloma, to see if we can intercept the disease. And definitely for multiple myeloma, we definitely have to treat those people, because then they're having symptoms and it's becoming life-threatening at that point.
So thank you so much. So it sounds like what you're saying, if we're just talking to the community and they, you know how it is, people get their lab values and they read them before their physicians read them. Now being able to have access to their portals, and they see these levels that are off, and they start going on the internet and start Googling. So I think what I hear you saying is that the advice is that there's definitely different stages, and not to be overly concerned if some of your levels are off, that you're looking at it as a kind of a full package about where you are, and that obviously you need to consult your physician and see what stage you're at and then what the next steps are for you.
Yes, yeah. And a lot of the ways that you can determine what those, if you have myeloma or not, is really to consult with a hematologist or a hematologist oncologist. That frequently, primary care doctors will do some of these tests because if a patient has, especially if an African-American patient has a bit of abnormal kidney function, one test to do is to do those serum protein electrophoresis and the free light chain tests. Or if the calcium is a bit elevated, they can do those tests. And again, because the incidence is so much higher in African Americans, we recommend that if you have a patient that's African American that has a high calcium level, or has low kidney function, or has anemia that isn't quite easy to figure out, that they do those two tests, the serum protein electrophoresis and the light chain test. Those tests will determine if 99% of the time, those tests will not show myeloma. However, if they do show myeloma, then it's life-saving because we can definitely treat multiple myeloma. And I think that, but how we diagnose myeloma is we do those two blood tests. If those are positive, then we look for those CRAB criteria of the high calcium, the renal, the kidney problems, anemia, and we do x-rays to see if there are any holes in the bones. And then the final test is we do a bone marrow biopsy. And that is when we get a small needle, we go right into the bone marrow area, which is right where the belt line, hits the waist. We take a small sample of those plasma cells, and then we open them up and look at what mutations cause them to be abnormal in the first place. And that helps us with staging and will help us with understanding what the treatment is. And of course, it will diagnose the disease.
Well, the perfect segue, because my next question is, for various different types of cancer, we hear about staging. And is multiple myeloma the same? And can you explain what that is in multiple myeloma? If you're having certain symptoms or you at a certain stage, if you can just run us through the basics with that.
Yes, and I think one of the triumphs of myeloma medicine was that we actually moved to. Oh, I forgot to mention that African Americans. We do know that part of the reason that African Americans have a higher risk of myeloma is that they have a higher prevalence of MGUS, or the precursor disease, and we know again that all myeloma begins at the MGUS stage. But going back to stage, one thing that we've done with myeloma is that unlike any other cancer, the stage of myeloma is based on the biology, on how the disease behaves. So decades ago, we used to stage myeloma just like all the other cancers were staged on where it is in the body and how much damage it's causing. And actually, as far back as 2013, we saw that there are certain blood tests that will let us know if the disease is going to behave poorly or not, and that we don't have to wait for someone to have lots of problems with myeloma to understand what stage they are. And stage does matter for myeloma. We used to, when we had the older staging systems, we said, oh, stage doesn't really matter because everyone is doing really poorly with it. Now that we have great new fantastic therapies, we actually base a lot of the treatment on stage. So stage 1 is when you have a low number of aggressive behaving plasma cells. And how do you know if you have aggressive behaving plasma cell? Well, there are 3 things. One is a chemical called beta-2 microglobulin. And that number is low. That means that the plasma cells are kind of sitting there, not doing very much. Another test is a lactate dehydrogenase. I mentioned that's a chemical when the plasma cells are dividing really rapidly that's released in the bloodstream. So if that's normal, then that means the plasma cells are again sitting there. And that when you opened up those plasma cells in that bone marrow biopsy, you didn't see any of those very aggressive mutations. And if you look over at stage 3 is when, again, we don't have to wait for people to develop problems with myeloma. We can understand what's going to happen even before the occurrence of bad symptoms. That if a patient has a high beta-2 microglobulin, those plasma cells are behaving aggressively. If the LDH is high, they're dividing rapidly. And if they have those high-risk cytogenetics, so the high-risk mutations, where they're missing their 17th chromosome, or their 14th and 4th chromosome are stuck together, or the 14th and 16th chromosome, or 1420, if they're stuck together, we know that the disease is going to behave poorly. And that when we intercept them with a more aggressive therapy to treat the myeloma. So stage 3 myeloma, we treat more aggressively than we treat stage 1 or stage 2. And so stage definitely does matter for myeloma in 2020, 2021 and moving forward.
So again, perfect segue. What kinds of treatments are available for active multiple myeloma? And can you describe each type of treatment and what's the science behind each one?
Oh my goodness.
Loaded question.
Well, it's really been, when I first started doing this, when I had hair, and I had no idea how to tie a bow tie. I barely knew how to tie a tie. 20 years ago, there were only two therapies. One was chemo pills and steroids, and the other one was IV chemo and steroids. And then people only lived about 2 years with myeloma. Now, because of all of the clinical trials and all of the research that's been done, it has completely changed. And the reason why there are 131,000 people living with myeloma instead of 47,000 people is that we now have a treatment sequence and regimens for myeloma. That when patients are newly diagnosed, they get an induction therapy. And the induction therapy is usually with a 3-drug or 4-drug combination. And basically, it's with a proteasome inhibitor, which really makes the plasma cells. I mentioned how those plasma cells like to produce lots and lots of protein. Well, the Velcade or the proteasome inhibitors, Velcade or carfilzomib or Ninlaro, are 3 drugs that we use, all in the same class. They kind of stop up the plasma cells from producing protein, which makes them real sick. There aren't any other cells producing protein in your body at the same degree that those myeloma cells are. So if you can stop up their protein production, that makes the plasma cells sick and leaves the rest of you alone. So the proteasome inhibitors, the other drug is Revlimid, thalidomide, or the IMiDs, what we call them, the immunomodulatory drugs. And those drugs are incredible because they get your own immune system to recognize and attack the myeloma, which is revolutionary when that came out. There was nothing else that was quite like that allowed your body to identify those plasma cells and kill them. And the third drug is dexamethasone. We still use steroids, which primes the cells for death with the other 2 drugs. More recently, we've incorporated the use of antibodies that stick to the myeloma cells, have your body identify those myeloma cells as abnormal and destroy them. So now we're using immune therapy along with the other 3 drug therapies. And then really that is one of the hottest areas of research showing incredible response rates. That response rates for induction therapy used to be back in the day about a 30% chance people would respond back when I had hair. Now the response rates are, now we expect 99, 98% response rates. We also now know that a consolidation with stem cell transplant really helps push the disease further down, further away. And the deeper you can bury the disease, the less problems you're going to have with it. And maintenance therapy, that we use maintenance therapy to keep the disease down. After you knock the bad guy out with the right hook of induction therapy, the left hook of consolidation therapy like stem cell transplant, maintenance keeps the bad guy down so he doesn't get up for a long time. And then when the disease does reemerge when patients relapse, then we have an open playbook of clinical trials and new therapies, which are really, there is not many other cancers that are keeping pace with all the new drugs that are coming out for multiple myeloma because of the clinical trials and because of all the research that's been going on.
So one question that I know a lot of my patients used to have is that you said that there's a variety of drugs that are in similar class that you could treat at those various stages. So how do doctors choose which particular drug that they would treat somebody with?
Yeah, that's a great question, and part of what I had kind of mentioned earlier, stage. So when they have stage 3 or they have high risk disease, then you start looking at a different set of drugs, and particularly the 4 drug combinations. So using those antibodies, using those potent proteasome inhibitors and IMiDs, along with the steroids, those high risk myeloma patients where they don't stay, kind of what determines risk is how long can you keep the bad guy down? How long can you, if you after you punch him out, how long can you keep it down before he pops back up? Higher risk myeloma will pop up sooner than standard risk myeloma or stage 1 or 2 disease. And so we pick regimens that are more likely to keep the bad guy down without coming up for as long as we can. And really, it's been clinical trials that we've done clinical trials in patients with these different combinations, and they've evolved over time. Definitely, not that long ago, about 10 years ago, we used to use 2 drugs. And the proteasome inhibitors and steroids, or the Revlimid or the IMiDs and steroids. Then we added 3 drugs on, and now the future is really looking like 4 drugs, because the great thing about clinical trials is that we have the standard of care, which back in the day was 2 drugs, and then we put it up against 3 drugs, and we say who's going to win that race. Patients benefit from being on both arms. They get the best standard of care, or they get the newest thing and the newest one. So now that becomes the standard of care. A new clinical trial comes up, and it competes to see who's better. So patients always benefit from going on clinical trials individually, but as a whole, everyone benefits, because then the standard of care keeps going up and up and up and up and gets better and better and better and better. And that's how we got to the regimens that we have now. And that's how we're going to move forward, like I said, very likely into 4-drug regimens for induction therapy for myeloma.
So you mentioned a lot about clinical trials, and we know that you're so involved in research. Can you discuss the basics about what a clinical trial actually is, from A to, I don't know if we have time for Z, but in a nutshell, what it is? And I think that sometimes people are fearful about hearing the word clinical trial, that it sounds strange, or it sounds that it's not standard of care. It sounds that they're going to be on something that is questionable. So can you explain to us what that is exactly?
Oh, yes. And so, and I won't go from A to Z, but I'll take a step back and say, decades ago, there were definitely atrocities in medical research that were people of ethnicities, Hispanics, African Americans, and Native Americans were subjected to medical experiments, not clinical trials, but medical experiments to that really were terrible. And we've never forgotten that. And as a clinical trialist and working with, all my best friends are clinical trial people, we've never forgotten that. But because of that, clinical trials have become really incredibly safe. They are so heavily regulated. And I would say specifically in myeloma, clinical trials are super safe. And the reason that they're so safe is that there's so many new drugs and so many things happening that only the best research ever goes to the point of clinical trials. So clinical trials are when we have a standard of care and we say, I think we can make that standard of care a bit better. And research is done to say, how can we do that? And if there's another drug that we can add on to the standard of care, then we have to prove that it's safe. And proving it's safe goes through animal studies, and then it has to be shown safe there. Then it has to go to the FDA. And the FDA will say, is this really safe enough for people? So I can't just, find a drug and then give it to somebody. The FDA has to approve to assure its safety. Once the FDA has assured its safety, then it does go to clinical trials, and patients start taking the medication to see what side effects are in people as opposed to animals. Once it's shown safe and is given to a small number of volunteers, and once it's shown safe in those people, then it moves into cancer patients to see what its safety is. And then more patients get treated with it. And once we say, yep, it's safe and it works, then it goes again to the FDA to assure its safety. And it gets peer reviewed by doctors everywhere to assure its safety. And then it goes head to head against the standard of care. And so those trials are the randomized trials, where in randomization, people very rightly so used to be very concerned about randomized trials, that they would receive a placebo. You can't receive a placebo in cancer medicine. It's against the law. You have to receive a drug to treat your cancer. And the randomization is that you get the best available care versus the best available care plus something new. And those two go head to head. If the best available care versus the best available care plus a new medication, if the new one doesn't work well with the best available care, then that clinical trial goes out. But patients still got the best available care plus something else. However, if that new therapy then beats the standard of care, then it becomes a new standard of care and the level of therapy goes up, which is how we went from having medications that work 30% of the time to ones that work 95% of the time, is because of that evolution. But really, clinical trials have never been safer. They are very tightly regulated. And really patients that are in clinical trials really receive superior care because they have so many people watching out for them. So they have clinical trial nurses, they have clinical trial doctors, they have their regular doctors, they have their regular nurses. They have everyone watching very carefully for any side effects, any symptoms, any changes to make sure and to assure their safety while they're getting the newest care that's available.
That was excellent. Thank you so much. We definitely got to Z and beyond. So I think you really explained what it is and not to be fearful of clinical trials, and that you're going to be at least getting the standard of care and then plus some. So we appreciate that. So basically, it sounds like you're encouraging patients when they're talking to their physicians to never hesitate to say, what is on the horizon? What are my options? What clinical trials are out there? And am I an appropriate candidate for them?
Absolutely. And one thing, if I can share my screen one more time, that I wanted to kind of bring up is that for African Americans, the clinical trial specifically for myeloma, clinical trial enrollment has been declining over the past several years. And when the FDA actually looked at myeloma clinical trials that were presented to them, drugs that are new regimens that were up for approval by the FDA between 2003 and 2017. They looked at how many, with this disease being so prevalent in the African American population, how many African Americans are actually on these trials. And what they found is that the median number of African Americans involved in clinical trials for myeloma was about 4.5%, as opposed to, again, the incidence in African Americans being twice that of other ethnicities. And overall, that African Americans are 20% of the overall myeloma population in the United States. Only 4.5% were involved in those clinical trials. Some places did awesome and enrolled 20% of African Americans, but some places, especially outside the United States, only enrolled 0.5%. The good thing is that the clinical trial enrollment was higher in the United States than in other countries, but still it lagged behind the overall clinical or the incidence of myeloma in the African American population.
So how, Dr. Cole, do you think we get that number up? Education?
Yeah, that's so. Yeah, and so that there are two things. One, I got several things. One is really an understanding of the importance of being involved in clinical trials. That when I talk to the trainees, the Hem-Onc fellows, I tell them, anytime that you apply a clinical trial to the patient in front of you, you have to ask yourself, is the patient in front of me reflected in the clinical trial? Because when they test it, they only test a clinical trial in bald guys. Then how do you know it's going to work for someone that has hair? And so representation in clinical trials is important because it helps you as a patient, but also it helps other African Americans that have multiple myeloma. And so one is awareness that there is a problem. The second is demystifying a lot of, and really engaging what has happened in the past and applying it to today, and really making sure that everyone understands how safe clinical trials are in 2021, and that there are benefits to individual patients because you receive the best care that is out there, but also that it helps African American patients and really the myeloma community as a whole. And the third thing, which is very important, is to make researchers aware, that my colleagues are aware that they need to really engage people of ethnicity into clinical trials. Because, part of the point of clinical trial enrollment for people of ethnicity is that sometimes investigators are shy, or they say, gosh, my patient is aware of the atrocities, and I'm sure that they don't want to be on the clinical trial. And so we're educating researchers and Hem-Onc providers that engage those atrocities of the past, understand that they happen, be aware of them, and don't let that happen again, and enroll people of ethnicity, because we need that to bring this forward in order to cure multiple myeloma.
So really decreasing the fear, increasing the education, and spreading the word.
Spreading the word, exactly.
Perfect. So being a researcher and so aware of what's going on, can you shed a little bit of light on what's new on the horizon and what you're excited about with multiple myeloma research?
Holy gamolies, that is gosh, there's so much. We have, in myeloma, we have more approvals for new drugs than most cancers, hands down. And really, we divorced ourselves of chemotherapy in the upfront treatment of myeloma decades ago. And now really we are moving more towards immune therapies to get the immune system more engaged to destroy the myeloma. One thing that we know is that T cells, are a type of cell that's in your body that patrols for cancer. And cancer cells are pretty smart in that they're able to avoid those T cells in the same way that when we're kids, we play hide and seek or we play tag. Those cancer cells have figured out a way to play hide and seek from the T cells, because T cells will destroy cancer cells. But cancer cells, and specifically myeloma cells, will work very hard to avoid those T cells. So now there are new therapies. One is called CAR T therapies, or chimeric receptor antigen therapies that reprogram your own T cells to kill the cancer cells, and only kill the cancer cells, which has been revolutionary. That it worked, and B, that it worked so well, and was rapidly approved by the FDA because of its efficacy. Also, T cell engagers, antibodies, as proteins that uncover those cancer cells. They bring them out of hiding so the T cells engage them and kill them. And new antibody therapies with new targets, which have really revolutionized myeloma. If you would have asked me 10 years ago, if you had asked me 5 years ago, would it be possible to get those T cells to kill myeloma cells? I'd say, I don't think so. I don't know if that technology exists. Now that is becoming one of the leading technologies. Also, gosh, I'll talk all day if you let me, but also targeted therapies. We talked about how African Americans have a higher incidence of that 11-14 translocation. Well, now we have new therapies just for that mutation. And when patients have those mutations, when combined with those other drugs, there's a publication that came out just a couple of weeks ago where they have like a 90% response rate, incredible responses just in that group. And now we're targeting some of those other mutations who specifically attack individual myeloma, so precision medicine. Mm-hmm. If you combine precision medicine as after lunch, and I can't talk, if you combine medicine with that T cell therapy, you bring those two together, I am very confident that, and I'm sure there's probably an even better technology out there. But when you bring that combination together, you really have the potential to cure a lot of patients with myeloma, and hopefully it will be, among our curative therapies moving forward.
So it seems like a really exciting future for multiple myeloma. And like you said, even within 2, 5, 10 years, so much can happen. So we'll definitely book you periodically and hear what's going on with the research on multiple myeloma. Can you tell us what resources are available for patients diagnosed with multiple myeloma? What's out there? What kind of help they can get?
Yeah, there are actually lots of fantastic sites. One is, of course, the cancer support community and the resources that they have. I've actually worked on their Frankly Speaking series and the books that they have, which help educate myeloma patients and their providers in understanding the disease, their disease better and what to expect. We're right now working on a what to expect with CAR T therapies, and we've worked on one for clinical trials. And so the cancer support community has just a wealth of information that's out there, including, virtual talks. I did a talk for the Gildas Club in Grand Rapids actually last night. It was last night. And really that is fantastic to have, researchers come to the community. I used to do it in person, but can't do it, with COVID going on. But to have researchers come and talk to patients, and more importantly, now it's important to hear researchers talk, but having patients talk to other patients to know that they're not alone with a cancer that is relatively rare as myeloma is. To have patients be able to engage and talk to other patients is critical. And so there, and also links to where clinical trials are also available through the cancer support community, but also cancer.gov, the warehouse of the National Cancer Institute, the NCI. If you go to cancer.gov, you go to their website, there's a big purple ball that will go everywhere with you. No matter where you go on that website, that purple ball will follow you that says, that is the link to their clinical trial engine. And so you click on that purple ball, you type in myeloma, and it will find clinical trials in your area. And can talk to your local provider and say, do you have this clinical trial available? Or can you refer me to someone that has this clinical trial available? And so those are just some of the resources that are available for patients with myeloma.
And not to hesitate being your own advocate, talk to people, talk to physicians. Don't hesitate to go to multiple places and get the information to get the best care for yourself.
Yes. So being empowered. There is, back when we had only 2 treatments, chemosteroids for myeloma, there weren't a lot of people empowered. Now, with I showed you that list of all the different therapies, of all the different decision making, of all the clinical trials that are available. It is really time to be empowered. It's an exciting time to be empowered, to be a myeloma patient and ask. We always recommend patients get a second opinion. I receive a lot of second opinions. When I have myeloma patients, I get second opinions from my colleagues because it's good for patients. It's good to have, it's good for me, it's good for patients to hear the same thing from somebody else and from a myeloma specialist, because myeloma care is very complex in 2021 and in moving forward. And so to get, to hear things a lot, to be empowered, to get a lot of information is really critical with this disease at this time.
Dr. Cole, if our viewers were to take away one thing from today's talk, what would you want them to leave with?
Boy, I would say for one thing.
Well, we can say three.
I would say to have hope and carry on would be, that's kind of my statement that my mantra that I kind of live by. But is to, have faith, have hope, and carry on. Have faith that that this disease is controllable, that people are living longer and longer with myeloma every day. To have hope that clinical trials are available, that new therapy is available, that there are myeloma specialists available, that when you're empowered, that you have hope that you can conquer the disease, and to carry on. I would say an important thing is to live your life. Once you got this disease under control, then carry on, live your life, enjoy life, and think about and not think about myeloma every day like we used to.
Perfect. Thank you. Hope is always wonderful, particularly around the holidays and the Thanksgiving holiday coming up, and to empower yourself, to advocate for yourself, and to have hope, because there's a lot of hope to be had. So thank you for that. So now's a perfect time for our audience. If you have any questions, to please drop them in the chat. And one question did come in about relapse and how treatment is different when relapse occurs. Can you talk a little bit about that?
Yes. So relapse is when a patient has myeloma, so their protein is high when they come in. And then they get those induction therapies, they get, sometimes they get a stem cell transplant, they're in maintenance, and their protein goes down. Because you remember that those myeloma cells produce protein, and therefore, instead of doing bone marrow biopsies once a month, we can just do a lab test. So the protein's at a very low level. And then at some point, because myeloma isn't curable yet, that protein will start to rise and the myeloma will start, the guy that we knocked out earlier begins to kind of rumble and move a bit. We don't allow the myeloma to come back full strength, that we actually engage the disease before it becomes a problem again. And that's when we use relapse therapy. And the one trick about relapse therapy is that most patients will be on some type of maintenance therapy when they relapse. And that what we don't do is we don't repeat that therapy. So we don't go back to what worked in the past. We actually use a new therapy and a new class of drugs. And these days, outside clinical trials, 3 is a kind of the magic number, 3 or 4 is kind of the magic number in myeloma. Then we go back to a 2 or 3 drug regimen for relapse therapy. But we don't try and repeat the old therapy that we have. We use those novel therapies. And I mentioned, in the far-hand corner, there were like 2, lists of drugs that are available for myeloma in a relapse setting. That's when the playbook opens up, and really there's set guidelines of which combinations to pick. but there usually will include an antibody therapy, something different than what they relapsed on, and again, steroids.
Okay, perfect. And one last question that came in. So we know that genetics and genetic counseling play such a large part now in cancer treatments and all sorts of chronic illnesses. Does genetics play a part in multiple myeloma?
Now that's a great question. And so the other question was great, but this is a great question because all the great questions are ones that we still trying to figure out. And so the unlike breast cancer and unlike colon cancer, where we have identified specific genes that increase that risk of myeloma, the we haven't found that gene, that specific gene that relates to the risk of myeloma quite yet. And so genetic counseling, because we haven't found that gene, sometimes doesn't work as well for myeloma. We do, but as research moves forward, it will become more important. And I would say genetic counseling for other diseases, especially if there's myeloma and lymphoma and other cancers involved, definitely so. But for myeloma, we're still working on it.
Thank you. Dr. Cole, you have been absolutely phenomenal, extremely informative,
Thanks.
and I have learned a ton. Thank you for giving us your time and sharing all this important information. Thank you again to our sponsors, Amgen, Bluebird Bio, Bristol Myers Squibb, GlaxoSmithKline, Carafarm Therapeutics, Sanofi Genzyme, and Takeda for bringing us this wonderful Facebook Live. Wishing you healthy, happy holidays, and continued hope. It has been my pleasure to have you join us today for this wonderful conversation. If you have any conversations about multiple myeloma, the cancer support community, like Dr. Cole indicated, has excellent resources for patients and caregivers, including information about treatments, testimonies from patients and caregivers, videos from healthcare providers, booklets, and worksheets for starting conversations with your healthcare team. Please visit us at www.cancersupportcommunity.org/multiple myeloma or connect with our experienced and licensed navigators at our hubline. That number is 888-793-9355. Again, 888-793-9355. Thank you for participating. Enjoy the rest of your day and happy holidays.